Several studies have shown that insulin-OHA combination therapy may have significant benefits on glycemic control over insulin monotherapy. To discuss on this topic, more combos, less insulin, we have our next speaker with us, Dr. Subhodip Pramanik, consultant endocrinologist, attached with Neotia Getwell Multispecialty Hospital. And to chair this particular session, I would like to invite Dr. Mary De Cruz, renowned diabetologist and physician, Vice President of DAY, and Dr. Professor Dashuruthi Shorkar, eminent endocrinologist and former faculty, SSKM Hospital, Kolkata. I would like to request both the chairperson to please take your seat and introduce our speaker.
Good afternoon, everybody. We know we don't want insulin. Painful, we don't want insulin. Tablet is much more preferable. So, combos are very important. One drug is not sufficient. 2 drugs, 3 drugs combination is much more preferable. In this respect, I invite Subhodip. He will describe all about combos and insulin, what is better, what is bad, what is ugly. He will describe by Subhodip.
Right. Can I have my slides, please? So, thank you, Chairperson Sir, and thanks Howrah Town Diabetes Study Society for inviting me to today's presentation, where I'll be interested in an integrated way that whether more combos means less insulin or not. What I mean that we already had so many drugs, metformin, glimepiride, pioglitazone, the gliptins, the SGLT2 inhibitors, and we already know that if we add one after one, then definitely you are going to get a better benefit from glycemic point of view. But the question here arises that if I start a combination early, does that mean that we are going to defer the insulin therapy? So, sequential therapy or early combination, which one is better? That the question that I am going to answer in next 15 minutes or so. So, what does actually mean that less insulin? It can be either a less initiation of insulin, that means we start late, or if we start insulin, there will be lesser dose or lesser number of pricks of insulin when we start early combination therapy. So, to discuss the thing in a detailed way, let us see what's the current situation in India. Basically, this ICMR India study published just last year actually have shown that India is actually in a horrible situation. Why? The prevalence of diabetes is 11%. Okay, 1 out of 10 is diabetic. But the prevalence of pre-diabetes is 15%. That means the number of patients who are having pre-diabetic state is more than those who are having diabetes. What does it imply? Given the fact that in India, the conversion rate from pre-diabetes to diabetes almost 15 to 18%, in very near future, the number of diabetic in India is going to boom. So it will increase up to at least 20% in next 10 to 15 years of time. So it's our job, it's our duty to tackle this burden of diabetes from the very beginning and actually protect our patients, protect their organs from being damaged. Now, given the fact that type 2 diabetes is a progressive disease, so the day you become diabetic, already 50% of your beta cells are lost. And as the days progress, more and more beta cells are getting damaged, and that's why it needs to be tackled from a very beginning, and we must have some agent which protects the beta cell. Because when the beta cell gradually goes down, your number of ADs, number of insulin pricks increases, and at the late stage when you become very insulinopenic, you just behave like a type 1 diabetic with multiple subcutaneous insulin injection. And type 2 diabetes is not a single disease, it has multiple pathologic defects, and that's why we need agent which acts through all the pathologic defects for development of diabetes. Now, Indian scenario, I was discussing that we diagnose diabetes late. So be it a clinically diagnosed or be it a diabetes diagnosed through screening, the average A1C is around 9% or 8.3%. So that means forget about 6.5, which is the cutoff of diabetes according to the American Diabetic Association. Even in screening, we diagnose when their HbA1c is 8.3%. That means on an average, our beta cell is almost 60 to 70% lost when we diagnose diabetes in India. So we are fighting for the less 30%. And monotherapy is not the solution because already I've discussed it's a progressive disease. Sedentary behavior, the current lifestyle, the diet, everything is making diabetes more progressive. High dosage may lead to adverse effects because you have seen, I am very sure that at least in my practice, metformin 2 gram monotherapy, none of my patient takes because most of them do not tolerate, and even who do tolerate do not achieve good glucose control unless we combine them with another gliptin or SGLT2 inhibitor. And presence of comorbidities are again important, where most of our guidelines now suggesting to start with early combination according to the comorbid situation. Now, what therapy? If you go through the timeline, insulin was the first therapy to be discovered for management of diabetes, almost 100 years back. After that, gradually came the sulfonylureas, then metformins, AGIs, gliptins, SGLT2 inhibitors, GLP-1 analog. Now, today in 2024, we have a lot of drugs which we can use to manage type 2 diabetes and also try to prevent its progression. Now, the question today was combos. So why combination? There are a lot of benefit of a combination therapy. If I make it a nutshell, there are two-prong action of a combination therapy. One, it makes other drug complementary to each other. That means more efficacy. And as a lesser dose sometimes required, combination leads to lower side effect. The dose-related complications are less. And I'll show some slides where usage of one drug with another actually leads to lesser side effect of a particular drug. Now, where do insulin stand here in an era of combination therapy? This is the latest AACE guideline, where they have shown how to start in OHS, in which situation what is important. Can anyone find where insulin is? Yes, it's there. In a very small area where it has been written, if your NT1C is more than 10 or fasting plasma glucose more than 300, that is the indication for insulin. But the rest, 95% of the picture is talking only about the OHS and GLP-1 analog. So it's very clear that with the advent of newer combination therapy, newer OHS, GLP-1 analogs, the role of insulin has been pushed toward somewhat lower area, where in definite indication, where there are osmotic symptoms, the patient in crisis, that is the situation where we can start insulin. So clearly it's less insulin with more combos. Now, NEJM 2021, the two-day study group is a very interesting study group that have shown that if we treat with metformin, these are the patients with young type 2 diabetics, the first year in metformin monotherapy is quite efficacious. But what about the subsequent years? Second year, third year, fourth year, less than 20% of our patients are going to achieve good glucose control. And what used to in our student life, our ADA guideline used to tell, start with lifestyle intervention for 3 months, wait for 3 months, check A1C, then add an OAD, wait for, and mostly it's metformin, then wait for 3 months, check HbA1c, then add the second OAD, then wait for 3 months. But gone are those days. Now even the ADA guideline do feel that if we go on this conventional approach, we are basically losing time. So it happens actually that the day you diagnose A1C is 9, with lifestyle somewhat HbA1c comes down, just again to rise in future, then you start another one agent, then 2 agent. So the average A1C throughout the life course of a patient is more than 8%. So what's the point in treating like that when you cannot achieve our recommended HbA1c level of 6.5 in young adults? So earlier achievement of glycemic control with early combination therapy is need for the hour. And that's why different guidelines, I'll not go through all of them, but they have focused on early combination therapy where you can achieve a better glucose control, a better comorbidity control, and I'm not going into the detail, ADA guideline have clearly, I'm very sure everybody have seen this picture more than 100 times, that in CKD, in heart failure, in cardiac patient, what we should be doing. This is the AACE guideline I've already shown. Even the ESC guideline, the cardiologist guidelines, they recommend early starting with SGLT2 inhibitors, GLP-1 analog. Now, the basic question with what I started is, does combination therapy delay insulin initiation? That means just imagine one group you have started a conventional approach, one agent, failure, second agent, failure, third agent. The other group you have started very early combination therapy, maybe 2 drug or 3 drug from the very beginning. So does that mean that this early combination therapy is going to delay the insulin? You may think that 2 drug, okay, but one day it will fail, the addition of third drug will be needed. Yes, it's true. But I'll show one data where it will definitely give a reverse answer. Definitely early combination therapy is beneficial. So that is the VERIFY trial with vildagliptin and metformin. It was the first trial to investigate the long-term clinical benefit of early combination therapy, 2-drug combination therapy versus the standard of care metformin monotherapy followed by a second agent, then third agent. So here in this trial, we were taken patients of HbA1c between 6.5 to 7.5. That means relatively early in their stage. And if you compare from the other trials, you can see the average A1c in this trial was very low as compared to the UKPDS ADOPT and ACCORD trial, where combination therapy was given in one group, the other group was given metformin monotherapy, and they waited to fail, they waited the A1c to rise after above certain level. And what did they do? When HbA1c rose above 7%, they added another agent. Obviously, it's very quite obvious that when we are treating a group with metformin monotherapy, that group will fail early because it has only one agent, the other group has 2 agents. Exactly that was seen. The treatment for initial failure was reduced by 49% in combination therapy. Well, I am not very interested in this data because it was quite obvious that when you were using 2 agents, it will fail less. But what was interesting to me was the time for secondary failure. That means when we added another agent in the metformin monotherapy group, that group also failed after some days, and that was termed as a secondary failure. The early combination therapy, the number of patients who failed at that time, it was compared between these 2 groups. And it was seen that the secondary failure, that means addition of third drug in both the group, it was delayed in those with whom we started with combination therapy. So that means the group of people whom we initially started with combination therapy, secondary treatment failure was reduced by 48%. So addition of third agent, be it a SGLT2 inhibitor, be it a sulfonylurea, or be it an insulin, was delayed. So this VERIFY trial actually showed the pathophysiological mechanism behind that. When I was showing the chart with beta cell function preservation, there I stressed that we must have an agent which cause beta cell preservation. It's only then we can actually protect our patient's beta cell and actually reduce the need for insulin therapy. VERIFY trial demonstrated that the beta cell function in the early combination group was preserved as compared to the sequential therapy group, and that is possibly the reason why secondary failure was delayed in early combination therapy. So VERIFY answered my question, do initiating with dual combination right from the beginning have a benefit versus the initiating with single drug with sequential increase in drug? The answer is yes. So more combos, less insulin. So it changed the guideline altogether. It's the pre-VERIFY trial, the ADA guideline. There was no mention about the combination therapy. They said you may try, it can be a choice, but post-VERIFY, they have said that early combination therapy can be considered in some patient at treatment initiation to extend the time for treatment failure. And what I feel, it should not be some patient, it should be all patients, because who doesn't want to delay the treatment failure, right? So early combination therapy is now the rule. Lastly, I'll talk about a royal combination of DPP4 inhibitor and SGLT2 inhibitor. Why I'm bringing this to today's context? Because another thing we want to focus is to target all pathophysiological defects of diabetes. So that's why the ominous update, the famous picture by Dr. Di Fronzo et al., there everybody have seen that there are at least 8, if not more, pathophysiological defects of diabetes, why diabetes do develop. And SGLT2 inhibitor DPP4 combination have shown to complement each other actions, not only the potentiating its efficacy, but also reduces the adverse event that is associated with one agent. Again, complementary mechanism for control of beta cell dysfunction, hepatic insulin resistance, and even hyperglucogonemia that is seen with SGLT2 inhibitors is neutralized by the DPP4 inhibitor. And not only that, it has been shown if we start with the combination therapy, the incidence of genitourinary tract infection is reduced in the combination therapy group as compared to monotherapy with SGLT2 inhibitor alone. So again, combination not only increases the efficacy, also reduces the side effect. Two very famous trials I'd lastly mention, the Indian experience of combination therapy of metformin, dapagliflozin, and sitagliptin, that is an SGLT2 inhibitor, DPP4 inhibitor, and metformin. The MESITA trial, again, they have shown they are superior as compared to dual therapy of metformin, sitagliptin in terms of HbA1c reduction, good control of fasting TP, and favorable safety profile. Another trial, it was published recently, and the same event, fixed dose combination of DAPA, sita, metformin in type 2 diabetic patient, poorly controlled, and it also showed that it was significantly better in achieving glycemic control versus dual combination therapy with poor control with metformin without any significant safety concern. So clearly more efficacious, less side effect. But does the benefit end here? No. Obviously, one, I have already mentioned, multiple pathophysiological pathways are counteract, additive efficacy, lesser side effect. But the two more important and why they are gaining more preference to our patient is one, better compliance. When you combine all three drugs in a single pill, patient feels that taking a single drug. Earlier, when I used to practice in medical college, SSK Medical Hospital, there we used to have drugs individually. Metformin 500 was available, vildagliptin 50 was available, canagliflozin was at that time available, the glimepiride was available. So if I use a triple drug therapy of a metformin, 500 metformin, then gliptin 2 tablets, total 6, and an SGLT2 7 tablet in a day, definitely reduces the compliance. And if I can combine all those drugs in a single pill or at least twice in daily pill, that becomes a very easy thing to comply with. And lastly, the lesser cost after the off-patent thing with the gliptins and SGLT2 inhibitors, the combination therapy cost has been coming down. And that's the beauty of this combination therapy, where with just 2 tablets in a day, we can give most of the sulfonylureas, full dose metformin, the full dose DAPA or any SGLT2 with gliptin in just 2 single pill, and patient compliance becomes much better with lesser cost therapy. This is my last slide, the case scenario. One case scenario I want to discuss, and I'll go through the timeline. When we are practicing, we are students in 2010, 11, had you seen this patient, 55-year male, diabetic for 15 years, BMI of 27, blood pressure 138/80, on metformin full dose 2 gram glimepiride, pioglitazone, still came with a higher fasting PP and HbA1c of 8.2. So at 2010, 11, that time we didn't have much of a choice. We could have given an alpha glucosidase inhibitor and that's all. And after that, insulin. But today we are in an era where we have a better molecule in our hand, and I'm sure at 2024, none of us will be advising insulin. We may counsel for insulin because early insulin counseling is important, but definitely we have more drugs in our hand with which we can manage this patient, and combination therapy is definitely delaying the insulin in these particular patients. So to conclude, monotherapy is inadequate for the management of type 2 diabetes because of its relentless progressive nature. Combinations are associated with more efficacy, lesser side effect, improved compliance because the number of pills goes down. Early combination have shown to prevent secondary failure, that is addition of third drug or fourth drug, or at least third drug is reduced in verified trial. Combination of SGLT and DPP4 inhibitors in vogue because definitely of more efficacy, less side effect, and easy to use. And combination in addition of insulin, that part I didn't touch much because of lack of time, are again a great choice because basal supported oral therapy is very important and very useful in management of diabetes in current era. So I'll stop here and over to the chairperson, sir. Thank you.
Thank you for an excellent talk, Dr. Pramanik. you really clarified that even though we have very high HbA1cs now, we can still avoid giving insulin with equally good results.
Yes.
So if there's, since we are running 1 hour late, just one question will be allowed. So if there are no questions, we close this session.
Thank
Thanking
you.
my co-chair,
Thank
Dr.
you.
Dash.
Thank you so much, Speaker. Thank you, Chairperson. It's time to facilitate our Speaker and Chairperson. I'd like to invite Dr. Abhay Kumar, sir, to please facilitate our Speaker and Chairperson. Thank you so much, sir.